is about intracellular hemorrhage. In contrast to ischemic stroke, our weapons for intracellular hemorrhage are limited. The first speaker in this important topic is Hye Bon Jong from Department of Neurology of Chungnam University Hospital. The title is Neurological Perspectives in ICH Treatment. Professor Jong, thank you.
Good evening, I'm Haebong Jung from Jungang University Hospital, and I'm gonna talking about neurological perspectives in ICH treatment. Intracerebral hemorrhage ICH is the end result of a number of pathophysiologic processes where blood is extravasated into the brain parenchyma. These processes are divided into either primary or secondary ICH. Primary ICH refers to hemorrhage resulting from hypertension or cerebral amyloid angiopathy. The focus here will be the management of primary ICH, but the treatment of ICH is one of the most difficult problems facing neurologists, neurosurgeons, and neurointensivists. In spite of advance in medical technology, the outcome for patients suffering from a spontaneous ICH remain bleak, with mortality rate reaching 62% within the first year of the onset. As you know, hypertension is the single most important modifiable risk factor and the most common cause of primary ICH. The pathophysiology of hypertension-related ICH is the harmful effect of persistent elevated blood pressure on penetrating arteries and arterioles. And this chronic exposure to elevated pressure causes progressive hyalinosis and sclerosis of these arteries, resulting in weakening of the vessel walls. So, the combination of high blood pressure, weakened vessel walls, development of microaneurysm, and low resistance of brain parenchyma lead to the ICH. Cerebral amyloid angiopathy (CAA) has been implicated in a number of neurological conditions, especially lobar ICH. CAA is the primary cause of recurrent lobar hemorrhage and characterized by deposition of amyloid beta peptide into the wall and adventitia of capillary, arterioles, and small arteries of the cerebral cortex. Eventually, amyloid beta deposition in cerebral vessels cause severe vascular dysfunction, smooth muscle cell loss, leads to vessel wall weakening. Generally, non-contrast CT is considered the gold standard for the detection of ICH. This is an example of a large vasoganglia ICH with intraventricular extension. Size and ventricular involvement are both independent predictors of worsening outcome. And the red arrow, which we call the spot sign, 1 mm focus of contrast extravasation on CTA, is associated with hematoma expansion. In neurological perspectives, to prevent progression of hematoma expansion is most important. Patients with ICH are at high risk for early deterioration and should initially be cared for on intensive care setting. We will have some problems during ICH management, and the table is general issue for ICH. Blood pressure is often elevated in patients with acute ICH, so BP monitoring and treatment is a critical issue. The target goal of BP in the acute stage has continued to controversy. The reduction of BP have beneficial effect on decreased risk of rebleeding and hematoma expansion, but might have potential risk of tissue ischemia at the hypoperfused penumbral zone in the perihematomal area. The INTERACT-1 trial randomly assigned 400 ICH patients in 6 hours of onset to either intensive BP lowering group, which target systolic BP below 140 mmHg, within 1 hour, or control group for target systolic BP below 180 mmHg. So to investigate proportional change in the hematoma volume at 24 hours in two different groups. The result of INTERACT-1 trial found early reduction of systolic BP to less than 140 mmHg to be safe. The ATTACH-1 trial was conducted to determine the safety and feasibility of reducing BP in the acute phase of ICH. The patient with ICH within 6 hours of symptom onset, systolic BP above 170 mmHg, and hematoma volume below 60 ml were assigned to 3 tiers according to the systolic BP lowering course. The investigators found no significant relationship between systolic BP and any of the outcome. These two pilot trials failed to show efficacy of rapid intensive BP reduction. However, results of two pilot trials provided an important proof of concept for early intensive BP lowering in patients with acute ICH. Two landmark clinical trials were performed to evaluate the efficacy of intensive BP reduction in patients with acute ICH. The INTERACT-2 trials, patients with a systolic BP between 150 and 220 mmHg within 6 hours of the ICH onset, were randomly assigned intervention or control group. Intensive BP lowering demonstrates a trend to association with primary outcome defined as modified Rankin Scale score of 3 to 6, but the relationship did not achieve statistical significance. Two possible conclusions can be drawn from this study. First, aggressive blood pressure lowering presentation seems to be safe in the acute phase of ICH. Second, a lower blood pressure target might have an impact on long-term outcome. Another randomized clinical study, the ATTACH-2 trial, compared treating the systolic BP below 140 mmHg versus below 180 mmHg in 1,000 patients with ICH within 4.5 hours of onset. Intravenous nicardipine was used in this trial, while multiple agents were administered in the INTERACT-2 trial. The study results demonstrate no difference in the rate of death or disability, as a score of 4 to 6 on the MRS scale at 3 months between the two groups. In the intensive BP reduction group, there was a trend toward a lower rate of hematoma growth, but not significant, and intervention groups experienced a high rate of renal adverse event within 7 days. In conclusion, acute lowering of SBP to 140 mmHg is safe and might be beneficial to patients with higher risk of hematoma expansion, but it does not seem to improve functional outcome, and SBP levels of 130 mmHg might be associated with increased complication as a acute kidney injury. Fever after ICH is not uncommon, and fever is correlated with hematoma growth and neurological worsening, and the duration of fever is related to clinical outcome in ICH patients. Two preliminary data demonstrated that therapeutic hypothermia reduced perihemorrhagic edema after large supratentorial ICH, but not been sufficiently studied in ICH patients and has yet to be given high level of evidence. The primary neuronal damage and blood product increased seizure risk after ICH. Seizures occur in 5 to 15% of these patients, usually in the first few days of hospitalization. Prophylactic anticonvulsant therapy is not indicated in ICH, but in patients with depressed mental states out of proportion to the degree of brain injury, continuous EEG should be considered and decided on anticonvulsant therapy. This is my take-home message of this lecture. First, acute lowering of SVP to 140 mmHg is safe, but SVP below 140 mmHg might be associated with increased complications such as acute kidney injury, and might be beneficial to patients with higher risk of hematoma expansion, such as larger hematoma, positive of spot and sore sign on CT scan. Second, prophylactic anticonvulsant therapy is no evidence in ICH patient. Last, therapeutic hypothermia should be considered to prevent secondary brain injury by uncontrolled fever. I'm honored to have the opportunity to present at APSC, and thank you for listening to me until the end.
Thank you very much. Our next speaker is Eun-Jin Ha from Critical Care Center of Seoul National University Hospital. He's a neurosurgeon and a neurointensivist. His presentation is entitled Neurosurgical Perspectives in ICH Treatment. Dr. Ha, thank you.
Thank you, Chairman. It's a great honor to talk about my neurosurgical perspective on ICH treatment at APSC 2020. Today's agendas are as follows. First, I will talk about the theoretical background and shortcomings of what neurosurgery means in the treatment of ICH. Secondly, based on the results of major clinical trials, I will compare the effect of medical therapy and surgery. Finally, I will demonstrate some of our cases that actually benefited from surgical treatment and conclude with a new surgical approach. ICH causes primary and secondary brain damage. Primary brain injuries from the actual mass effect of the hematoma. Over several days to weeks, secondary damage occurs when inflammation and oxidative stress pathways are introduced by hemolysis. This process leads to accelerated apoptosis and further damages. Based on this pathophysiology, the most important thing in minimizing brain damage would be to remove the hematoma. Although surgery is theoretically the answer to ICH treatment, surgical complications are also well known. In particular, surgery to deep-seated ICH can damage normal brain tissue. Moreover, postoperative rebleeding, reperfusion injury, infection, and complications of general anesthesia may occur, which may weaken the benefits of surgery. Therefore, we need to compare the surgical treatment to medical treatment of ICH. The first RCT, which dates back to early 1960s. However, it is still a hot topic for debate. The most famous trials in this field is STITCH 1 and 2. The STITCH 1 was the first well-powered, multicenter, multinational randomized clinical trial that compares the benefits of early surgery to initial conservative management. The conclusion of this trial was that superficial ICH was the only group that might benefit from early surgery. Consequently, a second study was performed by the same group of investigators to test the hypothesis that patients with superficial hematomas within 1 cm from cortical surface could benefit from early hematoma removal. The inclusion criteria of this study was as follows. And patients with IVH, secondary ICH, or cannot be undergone within 12 hours after randomization was excluded. The conclusion of this study is as follows. There was no functional benefit and mortality gain from early surgery. In subgroup analysis of this study, poor prognosis group was the only benefited from the early surgery. Even though Stage 2 trial was well designed, there was some criticism. Firstly, too much patients were excluded, and too good patients were included. Lastly, there was a significant crossover from medical arm to surgical arm. When analyzing the results of previous RCTs using meta-analysis, it is still difficult to say that surgery is beneficial. Although statistically significant, but heterogeneity is so high. Some subgroup analysis, it is not statistically significant. Therefore, in the current guideline, surgery is not recommended for supratentorial intracranial hemorrhage firstly. However, can we definitely ignore the role of surgery, which is currently not recommended by the guideline and has not proven beneficial in various RCTs? In fact, the reason surgical ICH trials fail is because there are some limitations. Neurosurgical patients are difficult to recruit, and we do not know who is ideal candidate, and patients who are considered to benefit from surgery are difficult to enroll. Lastly, large crossover will occur. In the clinical setting, no neurosurgeons do surgery for this small amount of thalamic and pontine bleeding, and every neurosurgeon do surgery for this cerebellar hemorrhage and intraventricular hemorrhage. How about this lobar hemorrhage or significant amount of deep-seated hemorrhage with midline shift? Maybe most of neurosurgeons do surgery. Before neurosurgeons make decision, they always considered about hematoma expansion. Hematoma expansion is common, and the result of hematoma expansion is fatal to patient's outcome. There have been several studies to predict this hematoma expansion in radiological field, and it may be helpful to consider such findings as a target for surgical treatment. Especially classical approaches such as large craniotomy and craniectomy is good for patients with persistent bleeding focus or those who are expected to undergo hematoma expansion. Here I present a clinical case. Since in this patient, hematoma expansion was predicted radiologically, surgical treatment was considered. A small perforator showing active bleeding was found and coagulated during surgery. The patient fully recovered after surgery, and during the short stay in the ICU, osmotic therapy was not required at all, and no tracheostomy was performed. Sometimes neurosurgeons do craniectomy rather than craniotomy. Let's see the following case. A 47-year-old patient was declining in mental status during ER stay and was accompanied by 60 milliliter of ICH and 7 millimeter of midline shift. So, craniectomy and hematoma removal was performed. After craniectomy, measured ICP was less than 15 millimeter mercury, and the patient recovered mental status after 1 day. The patient benefited from craniectomy rather than craniotomy. Like in above case, patients with these findings might benefit from decompressed craniectomy, and this is relatively consensus. And I want to show additional good candidate for craniectomy in the clinical setting. If the patient with temporal lobe hematoma or suspected uncal herniation, the craniectomy is very efficient treatment tool. Even though I showed some benefits from craniotomy and craniectomy, but large-scale surgeries have limitation because of their complication rate. So recently, minimally invasive surgery has been in the spotlight. It is a method of removing hematoma through a small hole. We use stereotactics, endoscopes, or might get help from recent devices. However, minimally invasive approach might not be as effective in evacuating ICH, as you can see in this case. After minimally invasive approach, postoperative CT demonstrates no difference from initial CT. So, to enhance the efficacy hematoma removal, various methods are being tried. The most famous one is the MISTY trials. The researchers inserted drain into hematoma pocket and TPA was injected. Studies over 3 phases have demonstrated that the MISTY method is not as dangerous as expected. However, unfortunately, it didn't get any improvement in function or survival rate. Nevertheless, this study should be noted as it concluded that in patients with low residual amount of ICH strongly correlated with good neurological outcomes. Since only surgical treatment can quickly and effectively reduce ICH, it is one step closer to proving the value of surgery in the treatment of ICH. In conclusion, surgery is still an important treatment option for selective patients with ICH. We need properly designed studies to demonstrate the value of surgery. Thank you for listening.
Thank you for your informative presentation. Thank you very much. So, okay, let's start discussion for ICH treatment. Now there are no questions from the floor, and may I ask a question to the Dr. John? Okay, can I ask a question to you? So for acute phase ICH, systolic BP lowering to 140 can be recommended, and Japanese guideline also recommend to such a acute phase SBP lowering therapy. But on the other hand, I'm afraid of acute kidney injury. Do you have any way to safely carry out BP lowering therapy in acute phase? Can you have an answer from your routine clinical practice or clinical perspective?
Thank you for your question. I'm a lot of experience about treatment of ICH, but I have targeted SBP 140 to 115 mm mercury tightly by line insertion, and think the prevention of AKI is the most important thing by reduction. Then I have another measurement about of AKI. I have no about the function. Just
there may be the problem of the internet connection. So you mean that the target BP of 140 or 150 may be safe to prevent the complication of AKI?
I think between 140 to 150.
Okay, thank you very much. So how about the patient with very high SBP level? So some patients have the admission SBP of 240 or 220. I think these patients may have the higher risk of AKI after a strong BP lowering therapy. Do you have any comment?
And actually, the high BP patient is the have higher risk of AKI, but I think many fluid challenges prevention of AKI is the answer of your question.
Okay, thank you very much. So, there is one question from floor to probably to Dr. Ha. Dr.
Yes.
Ha, okay. Regarding surgical indication for supratentorial ICH, will you suggest how large is the size of ICH should be surgically treated?
I think if the patient have more than 60 milliliter of hematoma, I think they can be the surgical candidate. But if the patient have from 30 to 60 cc of hepatoma, it depends on the location and the patient's symptom.
So I imagine that the patient with thalamic hematoma, the 60 milliliter level may be the candidate, but 30 milliliter maybe
To 60?
To 60 maybe the maybe lower mild for surgery for
Yeah,
the thalamic hematoma. For the patient with thalamic hematoma, I think 60 milliliter the patient with 60 milliliter hematoma be the good candidate for surgery. But the 30 to 6 milliliter of hematoma may be too small to be radical surgical evacuation. You mean so the surgical I'm sorry.
Yes, I agree. If the patients have 30 milliliter of thalamic hematoma, he is not the definite candidate for the surgery. But if the patient has lobar hematoma, if the location is temporal lobe, I think it can be the candidate for the surgery. So it depends on the location.
Okay, thank you. I see. Thank you very much. And I have another question for Dr. Ha. So
yeah,
you presented the spot sign for predicting the hematoma enlargement. And do you think that the patient with high risk of hematoma expansion are good candidate for craniotomy? So are there any chance to prevent the further brain damage by surgery?
I think if the patient has high risk of hematoma expansion, we have to lower the BP, and they can be one of the good candidate for the surgery, because some of them has active bleeding during the treatment period. In that case, the surgery can be very effective treatment tool for them. But actually, if even though the patients have spot sign, some of them does not have active bleeding. So we have to differentiate what the patients will be get benefit from surgery. It's still the problematic point of the surgery, I think.
Thank you very much.
May I have a question to Dr. Ha?
Yeah.
The INTERACT 2 and the ATTACK trial failed. So, and do you have any BP goal in ICH patients?
In our institute,
Current BP goal in
current.
Yeah.
And our
the
BP goal,
after lowering trial failed. The no effective in BP lowering in ICH patients. Do you have any current guidelines in ICH patients?
Actually, there's no
practical or BP goal. Yeah.
Our practical BP goal for the ICH patients is usually from 140 to 180. But if the patient does not have IICP sign, we try to lower the lower than 140, because we still think, even though the trials are failed, there's a very important role of BP lowering to minimize the hematoma expansion.
You usually measure the intracranial pressure when performing the BP lowering therapy in acute phase. Usually measure the intracranial pressure before.
No, we just predict if the patient has some signs of IICP, would think that they have IICP. I'm sorry. We do not measure ICP as a routine procedure, but if the patients have IICP sign, we try to measure the ICP by using parenchymal type ICP monitor.
We also do not usually measure intracranial pressure before BP lowering, and our goal is 140 or lower. Thank you very much. So the time is limited, and okay, there don't appear to be any more questions from floor. So thank you very much, speakers.
Thank you.
I'd like to finish this session by thanking all the speakers, audiences, and engineers. This session is now closed. Thank you very much. Stay safe and good night. Bye-bye.